So it's a pleasure for me to announce John Wilbur from Cleveland, Ohio, in the United States. He will talk to you about forearm fractures, not just another shaft fracture. John, thank you.
Thank you. Good morning. It's a pleasure to be here. I've spent most of my time this course at the master's course, but it's really a lot more fun to come down and teach the principles, because I think this is really where I think the enthusiasm is, and I think it's a lot more fun to teach down here, where really people are anxious to learn new principles and sort of move on. I'm going to be talking about the forearm. What you're going to find, even though you've been talking about diaphyseal fractures, this is a little bit different. It's a little bit different twist to it than some of the other diaphyseal fractures you've been dealing with. So my objectives is, number one, to review the concept of the forearm as a joint. And this is a little bit different concept to think about these diaphyseal bones as a joint, but they really sort of act that way. Secondly, to discuss the assessment, problems, and options that we run into in the treatment of these forearm fractures. Finally, talk a little bit about the surgical options and approaches and how we get there to do that. Discuss some of the complications and outcomes, and ultimately have you understand why it's not just another shaft fracture. This is a common injury, a relatively common injury. It's often the result of a high-velocity type force. Forces come from very different directions, either direct or indirect. There's many times a significant soft tissue component goes with it, and there's significant functional issues and multiple configurations. And I have this here that we have the radius on one side, ulna on the other side. And this is where we often treat, when looking at diaphyseal fractures, treat them as separate bones. But in reality, you have to realize that they must be treated together. You can never treat these bones separately. They work as a functional unit. You never injure one without somehow affecting the other part of the unit. They're never injured in isolation, and their function will be significantly altered if either one or other or both are damaged. And so the function of position the hand in space, which is really the function of the forearm, is to move your working unit, which is your hand, to different places in space and give it a motion and power. It requires mobility, stability, and alignment, and all these things are affected by injury. The anatomy you're probably somewhat aware of, and I don't want to spend too much time other than the fact you have two bones with very specific configurations. They're made that way because they have to work together, and any alterations in this configuration will cause dysfunction. You can see that both the bones have significant muscle coverage to it, and this coverage is both good and bad. It gives you support, it gives you the function, but it can also be damaged in an injury, and it can give you complications there, and it also creates the deformities that we see in forearm fractures. There are 6 major articulations here, and this is one of the reasons why these bones act as a joint. You can see they have the ulnar humeral articulation, radiocapitellar, proximal radioulnar, your distal radioulnar, the radiocarpal, and finally, and the one that we don't see and spend much about, but is the interosseous membrane, which can truly be damaged within injury, and it also can be damaged when you're trying to treat these things. So you need to be aware of all these articulations because they can be damaged, especially when you're thinking about when you're dealing with single bone fractures, is that you have to have a break someplace in this ring, and it may be through one of these articulations, and it may not be real obvious. There is special anatomies that goes together, and these bones do function as a unit, as I mentioned. They're tethered together, and the radius rotates around the ulna, giving us this ability to move the hand in a supination pronation. And this is a very unique type of way the bones to move. The other double bones in the body don't do that. So this is a very special part of the anatomy. The muscle forces that create this thing, also the ability to do this, also create deformity. And so when you have a fracture, these muscle pulls create significant deformities, which we see, and alter the alignment of our bones. The consequences of injuries are the same as most any other fractures. You have shortening, you have angulation, you have loss of the radial bow, and that's a very important concept we'll see as we reduce these things, this loss of radial bow. You lose loss of alignment, and most importantly, you lose the relationship between the two bones. There's a definite set relationship between those two, and as one is altered, it's going to affect the other one. It creates a dysfunction of this unit, and ultimately you end up with a disability, and that disability can be either short-term or long-term. Short-term if you fix it right, long-term if you don't correct it. We know, like any other fracture, there's various ways you can get a fracture. It can be axial compression, it can be bending, it can be rotation, it can be from direct trauma, and direct trauma in forearm is not at all unusual. What this determines is fracture configuration, displacement, degree of soft tissue injury, and associated injuries. And this is why we have so many different configurations in forearm fractures. It's because the mechanism by which they were determined, not only by the direction of the force, but the magnitude of the force makes a difference. In your clinical evaluation, once again, like most other injuries, you have to look at the soft tissue, you look for wounds, you look for swelling, you look for blisters. This helps you not only determine the type of injury, but also the timing of your surgery. Neurologically, there's a lot of major nerves that go down to give the function to the hand. So you have to be very careful on your neurologic evaluation. So every forearm injury requires a very detailed neurologic evaluation, which you do and you document. Also look for vascular problems. So vascular problems can be related to arterial injuries from the direct blow, or can be related to the swelling that comes from that, creating a compartment-time syndrome. And compartment syndromes are a devastating complication of these type of injuries, and you never want to miss one. Your radiograph evaluation is typical for most long bones. You want a full-length AP and lateral of the entire unit. This should include the elbow and the wrist. If you don't get good views, you want to make sure you get dedicated views of the elbow and the wrist to make sure you're not missing an injury in these areas. The CT scan you only need occasionally. If you have fractures extending down into the articular areas of the bone, it may be useful. If you're having problems with the joint on one side or the other regarding dissociation, you may want to get it. And the same way with an MRI. I think MRIs are occasionally indicated for injuries around the wrist when you're worried about DRUJ injuries. And so an MRI, though I wouldn't get it routinely, it may be indicated. Angiography obviously is only indicated if you're concerned about vascular injury, but don't hesitate to get it if there's any concerns. I'm not going to spend much time on classifications. You've already seen this, the classification for long bones. The radius and ulnar are 22, and then you have the A, B's, and C's, a simple fracture, a wedge-type fracture, and a comminuted fracture. And once again, this is broken down into the various groups, severities of A, B's, and C's. And it's a little bit different because sometimes you're talking about one bone, both bones, or a dislocation on these things. And so it's a little bit different than the other classifications, but it has the same parts. And so spend a little time looking at that on your own so you sort of understand how it is. But basically, you're going from A's or simple fractures to the C's or the worst fractures, and then there's variations of the various one bone, both bones combinations within those. There's other variations I think are very important to realize is that when you start seeing a fracture just of a single bone, you have to look at other combinations. This is a red flag that there's something else going on. And the two types I want to talk about is first the Monteggia fracture and then the Galeazzi fracture. The Monteggia fracture is an isolated fracture of the proximal ulna, which is usually displaced, and it has some type of dislocation of the radial head. The type, it's classified by the type, the direction the dislocation goes, and whether there's a fracture of the radial head. But the important thing to remember is that you have an isolated ulnar fracture, and you have instantly a joint injury of the other unit here, and that's what you got to watch for. And when you're treating these things, you got to treat both. You got to treat the bony problem, you got to treat the soft tissue problem. And the Monteggia fracture is just the opposite. It's at the other end of the bone. This is where you have, if you have the Monteggia is where if the radial head has to be lined up to the capitellum. And if you look carefully, sometimes it's very subtle, sometimes it can be missed, but if you draw a line down the length of the radius, it should always articulate with the capitellum. If it doesn't, then you have a subluxation or dislocation. The Galeazzi fracture is on a distal end, isolated fracture of the radius with the dissociation of the distal radial ulnar joint. It can be fairly severe in some cases, but it can also be very subtle. There are radiographic signs that you look for injury to the DRUJ. If you have a fracture to basal ulnar styloid, this is certainly indicative of an injury. A widening of the DRUJ on the AP X-ray. If you have a sublux ulna on the lateral X-ray, and if you have greater than 5 millimeters of radial shortening, these are all signs that there's been damage to this joint. So we're getting now into a little bit more about talking about the personality of the injury, and you've heard this many, many times, but it's very important, like any other fractures, to be aware of what this fracture is really like. What are the characteristics of these fractures? You have to look for soft tissue damage, you look for amount of fracture displacement, how much comminution, joint involvement, whether there's osteoporosis, whether there's neurovascular injuries. These are all important because these factors are going to go into determining not only how you treat it, but when you treat it and the potential complications you may run into. Your goals of treatment are, number one, to restore the relative length of both bones, the rotation, and the radial bow. And this is critical to do all these factors. If you don't do that, if you just do one or two of them, you're going to be disappointed. You also want to reduce all the joints. So once you get the bones stabilized throughout the length, you have to make sure the joints are reduced. Finally, you want to do a soft tissue repair because there is a lot of soft tissue damage, whether it be with the joints or the other tendons or ligaments around the area. You want to stabilize, and once again, type of stabilization depends on the type of fracture configuration. And the goal is always to get early range of motion, early functional motion of these joints. Otherwise, they will get stiff. And this is a tenet of any type of articular fracture. Which ones do we treat? Now, I say that some forearm, for some fractures you have seen in this course, do require non-operative treatment. The vast majority of injuries to the forearm in adults need to be treated operatively, and the literature supports that very well. Surgical treatment is indicated for all unstable both bone fractures, which is most of them. If you break both the bones in your forearm, these are mostly very unstable. They're rarely ones you can treat non-operatively. If you have displaced isolated fractures with greater than 10 degrees of angulation or 50 degrees of displacement, these need to be treated. This is your typical stick type fracture, which are not always benign injuries if they're displaced. Also, your Monteggi and Galeazzi fractures, your fracture dislocation patterns, and obviously every open fracture needs to be surgically treated. So what are your preoperative decisions? Obviously, you have to decide, once you decided you want to fix them, you have to decide how you're going to fix them. You need to talk about surgical approaches. There's 3 basic approaches. There's a Henry's volar approach, a Thompson's dorsal approach. These are both approaches for the radius. And then you have your Boyd approach or your lateral subcutaneous approach to the ulna. Which one do you do first? You have to decide you're going to do the ulnar first, radius first, type of reduction, type of fixation, then whether you're going to bone graft or not. And I'm just going to try to get rid of bone grafting right now. I know the original Anderson series recommended that you bone graft anything greater than 1/3 comminution. That was a very arbitrary number he came up with, and I think recent literature does not support that. I think that if you're careful with your surgical technique, I don't think any of these need to be bone grafted unless there's been bone loss. If you do a lot of stripping, you may cause dysvascularity of the area, and you may need it, but I think otherwise, I think there's rare indications for bone grafting. Now, you've already learned a little bit about the characteristics of articular injuries and diaphyseal injuries. And I know you're going to get into the articular a little bit more, but you realize with articular fractures, you want to have an open anatomic reduction. You want to have interfragmentary compression and stable fixation. Whereas diaphyseal fractures, we're trying to realign the bones to get length and rotation right. Often you can use bridging type fixation, and you can have relative stability for these things. And I'll tell you, in dealing with forearm fractures, there's variable elements of both. You're going to have to use these little bit techniques from both these camps because they sort of encompass both of them. So it's a little bit different than your true diaphyseal fracture. So you can see as you go across here is that this fracture, fairly simple oblique fractures, can be treated with a direct reduction, interfragmentary compression, and with standard techniques for diaphyseal fractures. This one with the wedges, you may want to go with direct reduction and pinning or screws through those wedges, but you may want to bridge them. There's no question here. You can treat that very differently. This is a bad soft tissue injury, so you're going to want to do very little soft tissue problems, and this is one you're going to want to bridge. So once again, all forearm fractures very different and treated very differently because of the fracture patterns you're dealing with. But the goal is still the same, to restore the relative alignment of both these bones, this unit. So let's quickly look at the different approaches for surgery. The subcutaneous approach to the ulna is a very typical approach. You can feel it on yourself. You feel the lateral part of your arm. You can feel the edge of the bone right there. It's a inner nervous plane, very simple to go down there. The thing you have to worry about is the little branch of the ulnar nerve, which comes down at the end if you go down distally, but fairly simple approach down through there. The posterolateral approach or the Thompson approach to the radius is certainly an option. I don't think people use it often because there's a lot of plate irritation, but it basically is just a radial to the mobile wad there and going down through. You really can't go too far distally because of the muscles crossing the bone, but it can be a good approach for middle or proximal third type fractures. There's no question that the workhorse for fixing radius fractures is the extensile Henry approach, the volar approach, that you go down through ulnar to the brachioradialis, and you need to know this approach. This is a very important approach for almost all fractures of the forearm. You use it for distal radius fractures, shaft fractures, proximal radial and ulnar fractures. So be very aware of this approach and spend some time learning it. Obviously, the dangers here are the sensory branch of the radial nerve in addition to the radial artery, but they're right there. You can see them, you can protect them, and know your way around there. How about timing of surgery? I think the vast majority of these fractures can be realigned, can be splinted, And you can then wait and do it in an elective time, unless you're getting into problems with neurovascular injuries or if they're open injuries. You want to have them in reasonable alignment, and once again, if you do this, if you're going to wait, you got to make sure that you've reduced the joints. There's nothing worse than sitting around and come in 2 weeks later, see a patient sitting there with a dislocated radial head or ulna. So you want to make sure that if you're going to wait, that these joints are reduced. You do need immediate fixation for open fractures, impending open fractures, those with compartment syndrome, and unreducible dislocations. So be aware of it. There are a lot of them you can wait on. There are a class of them that you have to be aggressive with and operate on fairly soon. So what are the surgical tactics that I can recommend to you that may help you a little bit? Once again, these are just suggestions. They're not written in stone. But in general, since you have two bones, you usually try to reduce the simpler fracture first. This will help set the length that you have to dial the other one into. So work on your simpler fracture first. You may want to do provisional fixation on that. You can put a clamp on it. You can put a plate on with a couple screws before you totally commit to it. And then you reduce the more complex fracture and get your provisional fixation. And then before you fix everything, you want to make sure that you're happy with your alignment, your rotation, your length, and get some x-rays before you go ahead and do that. And then you do your definitive fixation. Because once again, if you fix either one of the bones out of relationship to the other one, you're going to get a bad result. And so before you fix one, you got to make sure that the other one's going to match up with it. There's no question that the plate fixation is the gold standard for forearm fractures. There's very little controversy about that. It's stable, it's strong, you can get an anatomic fixation, and most of the series have shown a greater than 95% union rate with actually very few complications. So this is what you do in the vast majority of them. The type of fixation, the type of plate, you can use the LC DCP plate. You can use a locking compression plate. Usually they'll use it in the variety of a 3.5 size. The thing you don't want to do is use smaller plates. 1/3 tubular plate should not be used in the forearm. Has a very high incidence of failure. So you want a plate that is in the 3.5 family. And you want to get at least screws. They say 3 to 8 screws. Or 3 to 4 screws on either side of the fracture, depending on your fracture configuration. With your plate fixations, like anything else, you want to minimize soft tissue stripping. The vascularity of these bones, especially the butterfly fragments, rely on the periosteum and the muscle attachments. If you do too much stripping, you're going to devascularize the bone. You want to use narrow retractors. You want to avoid retractors through the interosseous membrane because you can cause synostosis if you do that. You want to do a very gentle reduction. You want to use a small pointed forceps for reduction. And you want to have extreme care with the butterfly fragments. And in many cases, you're almost better off leaving them than you would be to try to strip them, get them reduced. With the vascularity on there, it's a live bone graft, and so you don't want to disvascularize those areas. So here's a couple quick examples. Here's a fairly simple, straightforward both bones fracture at the junction of the middle and proximal third. Fairly simple fractures. One side is a short oblique. The other one has a little comminution to it. This is intraoperatively. The ulna has been bridged. We haven't tried to lag in that butterfly fragment just because of where it was, and it was already somewhat devascularized. Whereas the other bone, the radius, could be treated anatomically with a compression plate, interfragmentary compression through the plate. And he goes on to heal very nicely. And so once again, this is what you would expect. The bones have been realigned. You've not done any further soft tissue damage. And you've been able to get a good functional result because these bones have been lined back up again. And they've healed nicely, which is the case for most of these fractures. Another example, this is Monteggia fracture. You can see on the AP, it doesn't look all that bad. On the lateral, you can see that it's been displaced and shortened. It's been shortened greater than the 5 millimeters, and so I think that we do have the association of the distal radial ulnar joint. So this has to be treated that way. What you do, like anything else, you fix the bone. You want to fix it anatomically, bring it out the length, restore rotation, the length and alignment. And make sure you're maintaining your radial bow. And then you got to check your distal radial ulnar joint to make sure it's stable. And in this case, it was not stable. It didn't look like a bad injury, but it was worse than what we thought. It was not stable, and so this was pinned for a short time to get stability of that joint. And here it is healed. Radial bow has been restored. Length has been restored. And you would anticipate a good functional result from this type of injury based on the fact you've treated all components of the injury. You've not forgotten parts of it. Example of a Galeazzi fracture with a posterior dislocation of the radial head. The more important thing here is we have to straighten the ulna. So the ulna has been fixed with a posterior plate. The plate should sit posterior on these things here. You should tell your patients that this plate may bother them, may need to be taken out because there's not much skin, but that is the place to put these plates. You got to make sure that the ulna has been reduced adequately. The major reason for a persistently dislocated radial head is a malalignment of the ulna. And remember that. If you're sitting there, you get the ulna fixed, radial head still wants to pop out, go back and look at your reduction because you may have malreduced the ulna. And you may have to start all over again. Postoperatively, for almost all these fractures, you want to do temporary splinting, let the soft tissue rest for a very short time. You do want to avoid prolonged immobilization. In general, if you fix it internally, you don't want to fix it externally. You want to get these joints moving like any other joint. You got to get it moving, otherwise it's going to get stiff on you. You want to immobilize the minimal time needed to protect the soft tissues, and this may be changed at times if you have an unstable joint at either end. You may need to extend immobilization a little bit longer, but once again, the goal is to get these things moving as quickly as we can. Complications, non-union rates are low, but they do occur. Hardware irritation, synostosis, malunion, compartment syndrome, and occasionally refracture. Refracture we usually see after plate removal, and that's a whole other controversial subject. Outcomes for plates, for most of the studies, 98% union rate, very low complication rate, and this is even in the case of open fractures. How about other options for treatment? Just to very briefly mention external fixators. The indications are basically for bridging fixation for severe open fractures, which should be later revised to internal fixation when the soft tissue allows. It's rarely, if ever, used for definitive fixation. It's temporary bridging in these fractures. Intermedullary nailing is not routinely used. There's certainly problems with maintaining rotation, radial bow and shortening, and non-unions are a problem. It's really not appropriate for articular fractures. It doesn't give you the type of stability and alignment that you need. And there are problems with starting points. There's not ideal starting points. So it's rarely indicated, occasionally maybe in children, occasionally maybe in a single bone fracture, if you have bad soft tissue, and maybe pathologic fractures. I cannot remember the last time I used a nail on a forearm fracture, so it's used very rarely. So in summary, you need to have a complete understanding of not only the injury, but before that, the function of the forearm. You got to understand what the function is so you can restore it. You have to understand that this is a working functional unit, and that an injury to any part of this unit is going to give you problems, and you have to address all the injuries. Both bony and soft tissue injuries must be addressed. There are significant soft tissue injuries that go along with this you have to watch for and treat. It's a combination of articular and diaphyseal principles, though the goal is anatomic restoration of the bony relationships. How these bones relate to each other is what's critical. And finally, there's no question that plate fixation is the gold standard, and I think if done correctly, I think we can anticipate over a pretty consistently good result on these type of fractures. Thank you.